Welcome to Psych Waves, where we review emerging and current holistic treatments in psychiatry while learning to better understand the workings of our own minds. I'm your host, Dr. Teresa Anderson, owner and practicing psychiatrist of the Anderson Clinic in Cincinnati, Ohio. Today, we're tackling a crucial topic, the challenge of getting the right diagnosis. Have you ever felt like something was wrong, but your symptoms didn't quite fit into a clear box, or perhaps they were mistaken for something else entirely? Many illnesses share incredibly similar symptoms, making them tricky for even experienced professionals to pinpoint. This can lead to what we call misdiagnosis, where a condition is mistaken for another or missed entirely. This isn't usually due to carelessness necessarily, but to the sheer complexity of the human body and mind, and the often overlapping ways illnesses can show up. As my anatomy teacher told me during my first year of medical school at UK, when I found a bile duct on the wrong side of the body, well, I guess bodies don't read Frank Netter's Anatomy and Physiology. Translated, sometimes we just don't fit inside certain parameter boxes neatly. Today we're going to compare 4 pairs of commonly misdiagnosed psychiatric conditions. Our goal isn't to scare you, but to empower you with knowledge, help you understand the nuances, and encourage you to be an active, informed partner in your healthcare journey. Let's start with a classic case of mistaken identity, feeling down. Is it depression or hypothyroidism? The difference can be very subtle. So what is depression? We often think of depression as profound sadness, but it's much more than that. It's a mood disorder characterized by persistent low mood, loss of interest or pleasure, even in the things you used to find enjoyable, fatigue, changes in sleep or appetite, feelings of worthlessness, and difficulty concentrating. It's often linked to imbalances in brain chemicals and life circumstances. These feelings, to be diagnosed, need to have lasted for at least 2 weeks, where you're feeling this way more often than not. So what is hypothyroidism? This is actually a physical condition where your thyroid gland, a small butterfly-shaped gland in your neck, doesn't produce enough thyroid hormones. This can happen because of a brain issue. This can happen because it's a thyroid-generated issue. But these hormones are like the gas pedal for your body's metabolism. They control how your body uses energy. So why is there confusion? There's an overlap of symptoms. Both can have fatigue and low energy. Both can lead to weight gain. Both can have brain fog and difficulty concentrating. Both can lead to low mood and irritability. And while the root cause is different, the emotional experience can feel very similar. Both can cause changes in sleep. Both can cause excessive sleeping or insomnia. So how do we tell them apart? The biggest key differentiators are the physical symptoms. Hypothyroidism has physical signs that depression usually doesn't, like dry skin, hair loss, feeling cold all the time, constipation, or even having a puffy face. Depression symptoms are primarily mental and emotional, with the occasional weight gain. But testing, this is where it's crucial. Hypothyroidism is diagnosed with a simple blood test that checks your thyroid hormone levels. Depression is diagnosed through a clinical evaluation and symptom history. The impact of the misdiagnosis: treating hypothyroidism with just antidepressants won't fix the underlying thyroid issue, and you'll continue to have physical problems. A person's mood may not fully improve, if at all, and it's vital to check the thyroid function when depression is suspected, especially if the physical symptoms are present. And more importantly, if this is the first time you've ever felt depression, it's important to ask your doctor to check your thyroid levels before you consider starting an antidepressant. Part 2. The restless mind. Is it ADHD or PTSD? Next up, we have 2 conditions that can make a person seem restless, easily distracted, and even impulsive, both ADHD and PTSD. So what is ADHD? It's attention deficit hyperactivity disorder. It's kind of under one umbrella where it used to be separated out. It's an actual neurodevelopmental condition, meaning it's rooted in differences in brain structure and function present since childhood, and it affects how people regulate their attention, their impulses, and their physical activity levels. Symptoms can include difficulty focusing, concentrating, impulsivity problems, and sometimes hyperactivity. What is PTSD? Post-traumatic stress disorder develops after someone experiences or witnesses or even hears about a terrifying or life-threatening event. It's an anxiety-related condition where the brain's danger alarm gets stuck on the on position, leading to flashbacks, avoidance, and hyperarousal. And we're not talking about in the sexual sense here, but in the overreacting to environmental stimuli sense. So why is there confusion? Again, there's a significant overlap. Both have difficulty concentrating and focusing as a primary symptom, but in ADHD, the primary challenge is with executive functioning, your frontal lobes. In PTSD, it's often due to intrusive thoughts or hypervigilance when you're constantly scanning the environment for threats, or a dissociation where you can easily lose track of time or numb out with mindless activities like scrolling for hours. Both can make it hard to stick with a task. Both can have restlessness, fidgeting. ADHD often involves physical restlessness. For PTSD, a person might be restless due to anxiety or an inability to relax because they're on high alert constantly. Both can have impulsivity. Both conditions lead to impulsive behaviors, though the reasons differ. In ADHD, it's a core symptom of poor impulse control. In PTSD, it might be a desperate attempt to escape distressing feelings or situations or even perceived dangers. Both typically have irritability and emotional dysregulation. Both can cause quick tempers or intense emotional swings. Both can have sleep problems. Usually in ADHD, folks get caught up in a project or lose track of time or scrolling online or get interested in something and go down the Reddit rabbit hole. In PTSD, nighttime can bring about a fear of going to sleep because of fear of nightmares. And with there being less going on at night in general, unless you work third shift, then there's less stimuli to distract them from intrusive thoughts. So it can be a problem of both going to and staying asleep. So how do we tell them apart? The key differentiators are onset. For ADHD, the symptoms usually appear in childhood and are long-standing. PTSD symptoms develop after a traumatic event or multiple traumatic events like growing up in an abusive family or are directly related to it. The core driver for ADHD is about difficulty with self-regulation. For PTSD, the core driver is fundamentally about fear and the brain's reaction to trauma and trying to protect against similar and or future traumas or dangers. The hyperarousal specifics for PTSD involve specific nervous system hyperarousal symptoms like exaggerated startle response, nightmares, and flashbacks, which aren't typical for ADHD. The impact of misdiagnosis, treating PTSD as ADHD might mean missing the need for trauma-focused therapy, and you give a stimulant to a person who has PTSD, it could actually make their already overactive nervous system worse. Could you have both? Absolutely. In that case, we try to calm down the nervous system first, and if the concentration and task completion problems are still around, then we can look into medication options. Conversely, treating ADHD as PTSD could lead to ineffective therapy if the core executive function challenges aren't addressed. A thorough history, including any traumatic experiences, is essential for an accurate diagnosis. Part 3, the roller coaster ride, bipolar mania versus anxiety. Our third pairing highlights the intense energy and restlessness that can be seen in many different ways. Bipolar mania and severe anxiety. So bipolar mania is in bipolar disorder. It involves extreme shifts in mood, energy, and activity levels. Mania is the up phase, characterized by an unusually elevated, expansive, or even irritable mood. This can last for a couple days or even a week or so. People in a manic episode might have racing thoughts, a decreased need for sleep, feel incredibly energetic, talk very fast, engage in risky behaviors like sex with multiple partners when you're in a committed monogamous relationship, or using recreational drugs when you've been a teetotaler your whole life. You could have an inflated self-esteem or grandiosity, thinking you can do absolutely anything without long-term consequences, which isn't typical for your baseline personality. What is anxiety? It's a natural human emotion, but when it becomes excessive, persistent, and interferes with daily life, it can become a disorder. Generalized anxiety involves persistent worry about everything. Panic attacks are sudden surges of intense fear, and usually in response to a fear-inducing stimulus, like for some people going to the dentist or flying on an airplane or public speaking in front of a large crowd. The symptoms are usually time limited for panic, from a few minutes to an hour, and often include restlessness, feeling on edge, difficulty concentrating, muscle tension, sweating, dry mouth, and sleep disturbances. So why is there confusion between mania and anxiety? There's some common overlaps. Both have restlessness and agitation. They can make a person feel like they can't sit still or buzzing with energy or easily annoyed and overwhelmed. Both can have racing thoughts involving a mind that won't quiet down, jumping from one thing to the next. Both can have reduced sleep, but anxiety can cause insomnia because of worry. Manic episodes can involve feeling energized on very little sleep, feeling like you can run on fumes and not even needing sleep or food, sometimes just for a few hours at a time. You don't even feel tired. So in anxiety, you can't sleep even though you want to. In mania, you don't sleep because you don't feel that you need to. Both can have irritability, being short-tempered and easily losing patience, and both can have pressured speech. Talking very quickly and jumping topics can occur in both, though it's a hallmark of mania. When the person is talking nonstop, they are very difficult to interrupt, whereas the person who is anxious can stop and listen to the other side of the conversation. The key differentiators are quality of energy and mood. In anxiety, the energy is usually driven by worry and dread. The mood is typically distressed. In mania, the energy is often accompanied by an elevated or euphoric mood, grandiosity, and a feeling of invincibility, even if irritability is also present. There's risky behavior when folks are in a manic state. They're more likely to engage in impulsive and high-risk behaviors like excessive spending, maxing out your credit cards, reckless driving, wanting to have sex with everything that moves, because their judgment is impaired by their elevated mood and inflated self-esteem. This is not typical in pure anxiety. And there's a sleep need versus a sleep difficulty. Anxious individuals want to sleep, but can't due to worry, and manic individuals generally don't feel the need to sleep much, if at all. So the impact of misdiagnosis, treating bipolar mania solely as anxiety, can mean missing the necessary mood-stabilizing medication, leading to unchecked manic episodes with potentially destructive consequences for finances, relationships, and safety. Plus, it burns out your brain. It's like having a really nice car, driving a Lamborghini cross-country 200 miles an hour and not stopping for gas or to change the oil. Your brain doesn't like going super speedy all the time. There are a lot of folks who have inadvertently burned familial bridges, lost friendships and jobs because of unchecked mania. This is why it's really important to have a careful evaluation of mood shifts, not just anxiety. It's critical. Next, part 4, we're going to talk about the instability spectrum, bipolar disorder versus borderline personality disorder. Finally, we're going to look at 2 conditions often characterized by intense emotional shifts and relationship difficulties: bipolar disorder and borderline personality disorder. This pair is particularly challenging to differentiate, even for experts. So bipolar disorder, as we mentioned, is a mood disorder with distinct episodes of elevated mood or mania or hypomania, and then depressive episodes. The mood shifts are typically episodic, meaning they last for days to weeks or months, rather than shifting from moment to moment. Borderline personality disorder is characterized by pervasive instability in moods, but this instability can happen in seconds to minutes and back again. Difficulty in interpersonal relationships, poor or non-existent self-image, and reckless behavior. Core features include an intense fear of abandonment, unstable and intense, frequently short-lived relationships, unclear self-identity, impulsive behaviors, often self-harm or risky actions, and chronic feelings of emptiness and intense, rapidly shifting moods. So it's obvious to see why there's a lot of confusion here, because there's very, very significant overlap. Both have intense mood swings. For bipolar, these are episodes. For borderline, these can be rapid second to second, minute to minute, or hour to hour shifts triggered by interpersonal conflict, typically. Both can involve impulsivity, but the driver is different. In bipolar mania, impulsivity is often driven by grandiosity and a heightened energy. In borderline, it's often driven by an intense emotional pain, a desperate attempt to regulate overwhelming feelings, or a fear of abandonment. Both can have struggles with relationship instability, but in bipolar, it's usually due to the impact of mood episodes during their extremes, either mania or depression. When their mood is regulated and stabilized, they have fewer problems with this. But in borderline, it's typically driven by an intense fear of abandonment, perceived slights, idealizing then devaluing others. You're awesome, you're the best, you're better than sliced bread, and then you say something they don't like, and I hate your guts and I wish you dead, that sort of thing. Difficulty with emotional regulation within these relationships. They can have extreme overreactions to perceived emotional slights. And self-harm, it can happen in bipolar, especially during the depression part, but it's a hallmark feature of borderline. It's often used as a coping mechanism or escape for intense emotional pain, or a way to feel something physical when feeling numb emotionally. This can frequently look like superficial cutting, burning, or bruising themselves, in addition to non-fatal ingestion of substances or items in an unconscious cry for help or attention. The key differentiators are the duration of the mood shifts. This is huge. In bipolar, the mood shifts last days, weeks, or months. I'd like you to think of it in terms of seasons. When you're looking at the weather, we live in a temperate climate, theoretically. And so it takes weeks to months to sort of shift into spring, summer, fall, winter. In borderline, the mood shifts are often rapid, fluctuating quickly, often in response to immediate stressors, especially interpersonal ones. Think of that more like in terms of like a pop-up thunderstorm, right? It could be spring, winter, summer, or fall. You could have a quick change in the weather. Someone could be having a great day and then after fighting with their boyfriend, they spiral out of control and they say they're leaving or they're suicidal. That's kind of the intense overreaction to an interpersonal slight. So the chronic instability versus the episodic nature, borderline is characterized by the chronic pervasive instability across many areas of life: identity, relationships, emotions, career. Bipolar disorders, instability primarily revolves around the mood episodes. When they aren't experiencing the extremes of mood, they have far less instability. There's an identity disturbance in borderline that's not typical of bipolar, and there's a significant fear of abandonment is the central driving force in borderline, and less so in bipolar disorder itself. So obviously the impact of misdiagnosis. Misdiagnosing borderline personality disorder as bipolar can lead to prescribing mood stabilizers or antipsychotics that may not be the primary intervention needed. So with that, you have money, you have side effects, you have lab test problems. Borderline often responds best to specific psychotherapies like DBT or dialectical behavioral therapy, which teaches skills for emotional regulation, distress tolerance, interpersonal boundaries, and interpersonal effectiveness. Misdiagnosing bipolar as borderline can mean missing crucial information management for mood stability, which could then have both interpersonal and employment consequences. That's why a thorough diagnostic process by a seasoned clinician and appropriate history taking is paramount. In other words, this is not something that can be sorted out in a 15-minute visit. An example would be, when you say racing thoughts, what do you mean by that exactly? Because not everybody's racing thoughts mean the same thing. So as you can see, a lot of disorders have significant overlap with others. Here are some key takeaways you can use to empower yourself. One is trust your gut. If something doesn't feel right or if a treatment isn't working as expected, listen to that inner voice and ask questions. 2, be a detailed storyteller. Keep a journal of your symptoms, when they started, what they feel like, how long they last, what makes them better or worse, what happened to elicit this, or if you can't figure out a trigger for anything at all, any patterns that you notice. All this objective data is invaluable for doctors. Number 3, ask questions. Don't be afraid to ask your doctor, could this be something else? Or what other possibilities are we considering? We call it a differential diagnosis, or a running list of all the things it could possibly be, which as we take a longer history, we kind of trim the fat on that and kind of narrow it down. If the doctor is offended by you asking that question, then maybe that isn't the doctor for you. This isn't about ego here. This isn't about being right or wrong. This is about you as the patient getting the care that you need. And both you and your doctor need to be on the same team regarding that, right? So the next is seek second opinions. It's not rude. It's smart healthcare. You wouldn't just go to one dealership to get a car, would you? You'd shop around. You make sure that you're getting the right thing. You make sure it's a good fit. You make sure it's a good price, all the things. If you're not getting the answers you need or you feel dismissed, as we discussed above, a fresh perspective can make all the difference. And the other is find doctors or providers who actually listen to you. A good doctor or a therapist will engage with your concerns, explore all the different possibilities, and educate you at the same time, all the while working with you to find the right medication or therapeutic modality that will work best for you. We may not always tell you what you want to hear, but we definitely want you to have the information that you need to hear. We want to keep you safe. We want you to be well. Reaching out for help is the very first courageous step toward feeling better. It takes a lot. It's a big chasm to jump. Getting the right diagnosis is the second crucial step toward effective treatment and regaining control of your health and your life. It's a journey that requires patience, persistence, and self-advocacy. And I, for one, am so glad you're here. So if you found this information helpful, please like and subscribe, follow us, tell your friends. Follow our podcast, Psych Waves, on Apple and Spotify, our TikTok and Instagram at Anderson Clinic, Cincy with a Y. And if you happen to be in the Cincinnati area and are looking for assistance with treatment-resistant depression, anxiety, postpartum depression, PTSD, concussions, or stroke recovery, please give us a call at 513-321-1753 or visit us at www.andersonclinic.net. Start feeling better faster.